Great, thank you. So throughout the Q&A, some questions are broad, and sometimes we will present specific patient cases. So I'll present to you one in this context. So consider this patient case. A patient with early stage 1 breast cancer treated with breast cancer conserving surgery and radiation. What is the true benefit of endocrine therapy to this person, and is it needed for everyone?
So that's a great question. Let's kind of take it apart a little bit. So breast cancer is staged 0, 1, 2, 3, and 4, and the lower stages refer to smaller cancers that may not have spread to the lymph glands and generally have a lower risk of recurrence following surgery. So a stage 1 cancer is typically a very low risk of recurrence. Breast conserving surgery means that this patient had a lumpectomy or part of the breast removed, the part that had the cancer. After surgery, the reason that we consider endocrine or hormonal therapy is that even though the cancer has been removed, we are always worried about tiny cancer cells that may remain. They may either be in the breast or they may have traveled via the blood or lymph system to other parts of the body, and they may be too small to detect, but we certainly worry that over time, those cells could set up shop and grow and ultimately become metastatic breast cancer or breast cancer spread to the bones or the lungs or any other part of the body. The reason for the endocrine therapy is that we presume those cells are hormone sensitive, just as the breast cancer was, and that by giving the endocrine therapy, we can, in theory, starve the cells, and thereby we reduce the risk of the cancer returning and spreading, and we ultimately improve the chances that a woman will beat the cancer.
Great, thank you very much. I want to go through another patient case that we just received on the chat, and I'm going to read it. So the person is triple negative and did not start endocrine therapy until after mastectomy. She had neoadjuvant Taxol, Herceptin, and Perjeta, and now on Cadecla and Letrozole. Do you see a benefit to holding off on endocrine therapy, or is it better to start immediately? I am 50 years old and have chemo-induced menopause since June of last year. Is it Letrozole a endocrine therapy? So maybe you can help us on that.
So this is a very complicated case. This is a case that is hormone receptor positive and also positive for another marker called HER2. And in that case, we typically will give chemotherapy, Taxol plus HER2 targeted therapy before surgery. And then following surgery, depending on the results, we sometimes need additional HER2 therapies, and that's the Kadcyla. However, in the case of a hormone receptor positive breast cancer, following surgery and following completion of chemotherapy, that's generally the time that we initiate the endocrine therapies. Endocrine therapy, as you may know, goes on for many, many years. So there's not a precise date that it's, best to start. But in general, we would want to get started pretty soon after the surgery and following the completion of chemotherapy. And the Kadcyla therapy typically goes on for about a year or so. And it is generally recommended that the endocrine therapy be administered at the same time as that. And then once the Kadcyla finishes, the endocrine therapy